Hi everyone. Thank you all for joining the session and a very good afternoon to all. I think majority of you would have seen this kind of session organized by FCPA and at least some of them are fans for such programs. So this is myself, Pawan Kumar CM, PhD student in Adi Chuchungiri College of Pharmacy. This kind of sessions are there to learn about a topic, also to discuss the current issues. And so FCPI have came with launching this kind of session with the aim of discussing different aspects with the clinical pharmacist. I would actually help participants to get the life of CPs here. And coming to the speaker, today I welcome you, sir. That is Abde Hussain, sir. He have completed PharmD and currently working as a clinical pharmacist at Medcare Hospital, Surge. And also he have worked as a critical care clinical pharmacist for 4 years at Kingsway Hospital, Nagpur. And also he have gained experience in pediatric and also in neonatal specialist while working at Nilsson Hospital, Nagpur. So today he is going to take up the session about the ethical concepts in critical care hospital. So talking about critical care ethically, I would like to state two words. That is, if we kill concern in critical care research, we risk existing the very essence of medical progress. And also critical care is not about only interventions. It about a vigilance, adaptability, and also ethical responsibility. So, stating my these two words, I'll just hand over the session for Abde Hussain, sir. Yes, sir. The session is for you, sir. Thank you.
Thank you, Paul, so much for that kind introduction. And rightly said, there are a lot of differences between the research that we conduct in normal patients and the research that is conducted in ICU patients. So there's a fine margin, and there are a lot of chances of errors that can happen. So let us go through what all there are possibilities and how difficult it is to conduct a research in an ICU. So, my topic, ethics in critical care research. I do not have any relevant financial relationships with any commercial interests. The learning objects will be to just see the difficulties that one faces while conducting a research in an ICU. Then, what are the basic principles for conducting an ethical research? The equipoise, the term, and why is it necessary in every research? The risk and benefits that one needs to assess before conducting a research as well. So, ethics and research, the evolution of the concept. So, many frameworks and guidelines have been prepared since it came into existence in 1947 after the trials that were conducted on humans during the World War II. So that made everyone realize that there needs to be some groundwork, some rules and guidelines that needs to be followed to ensure that humans are not as treated as some any animal experiment. Even animal experiment is by far they have laws, their regulations, and how it is to be conducted. So in that same manner, humans also cannot be judged and treated in the same way. So any research that is conducted needs to ensure the safety of that patient. It is not like we consider if we put one person in risk so that others can benefit from it. So each and every individual is very important, and for that purpose, various throughout the history, throughout the cases that have occurred. Accordingly, these guidelines and these ethical uh, laid down various factors that needs to be considered. So the first one, the Nuremberg Code, this is the first one, then followed by the Helsinki Code. So after this, the Belmont Report came, which laid down the very fundamental aspects of ethical research. So like the informed consent came in, the principle of justice, equal access to participation, the research benefits, wherein, not just the benefits we reap out of it, but also at the same time, reducing the risk to individuals and making sure that we get the results out of it. So every year, these guidelines get updated. They are reviewed by various international committees, and henceforth, they are brought to the LAID framework. So, what are the ethical requirements of clinical research? So, first should be the social value. So, regarding the advancement in knowledge that we try to gain each and every day for this, that is why we conduct a research. So, in that, we should always think that we should gain some benefit, but at the same time, we should not put somebody in harm. So, that is a social value while conducting an ethical research. The second one should be scientific validity. It should be a sound scientific judgment. There should be a proper question that should be arise that why we are conducting this research. And if it is scientifically valid, then only this research should go ahead. Then a fair participation selection. What if we misjudge, we left out some group of people and we only see partiality towards some people only? So this will again create a rift. This will again create a lot of biases, a lot of disharmony among people. So everybody should get a fair chance for the trials. And it also helps us to know whether particular treatment are working in some people or no. That is why a lot of racial differences come in, and we have seen so far in history there are a lot of drugs that act on particular racial community, but it won't affect in another community. Probably the genetics working over there. Then the favorable risk benefit ratio should always be there. This is has to be always judged. What are the risks? What are the benefits? And how we can reduce this risk of harming the patients. Then an independent review should be there. Suppose you and I are both the conductors of the research. We'll try to gain as many as the subjects in our trial. And we might, just for the sake of including more people or whatever the best interests are, and we just might not, bifurcate which patients we should not include. So there should be always another set of eyes looking at this with another view and seeing that what all the possibilities and what all the dangers, the risks this study proposes, and how we can minimize by setting the inclusion and exclusion criteria. Next comes the informed consent. This is a very critical thing. In ICU, we have always seen that a lot of procedures are conducted. Anything, any admission, just right from the beginning of admission in ICU, we have to take consent. So in research also, the first thing that comes up is that we need to take an informed consent. We need to inform the patient what are the risks, why we are conducting this research, what will happen to them, and it is more detailed than a regular consent that we take in ICU. Then always the seventh and most important one, respect for enrolled patients. Just doesn't mean it's one more lab person that we are treating. No, each and every individual, no matter if they are in the research, we need to treat them as a particular patient and take those measures that suits them best. So in ICU, how the things are different. So first comes the complex decision-making process. Now, if we see a normal research project, it is very straightforward. But if we know it's a diabetes patient, we know we put on this drug and this drug versus this drug. The process continues. There may be a different variables because different weight, different height. So is in ICU. But what makes it different? So in ICU, there are multiple processes that are occurring. Patient might land up into sepsis one day, might be intubated the next day. So all these processes will have some other way they will impact the research study of yours. The unique thing about a critically ill patient is their pathophysiology. You have a whole different view of how the patient behaves. One patient is not similar to another patient and they will behave differently. Like in sepsis itself, there are so many phenotypes that have been trying to discover, like how one patient will respond to one treatment as respond to another treatment. And the prognosis is always changing, never can be predicted about this thing. So again, this is a very unique situation. And these patients have a very less tolerance to adverse events, or they are at a risk of exposure, more exposure to various risks. So maybe, a small dose also can have a huge amount of effect in these patients. The pharmacokinetics are changing, the renal clearance might decrease. So just how it will respond to a research molecule, that is very unpredictable. Then emergency situations. Now, if you are going for a well-planned trial, you will sit with the patient, will inform them everything in detail about this research. You will have time to, how to take this medicine, what are the further reviews. You will have to come back for follow-up and everything. You have a lot of time for that. But what about researches that are conducted in very emergency situation? A patient coming to an ER with trauma. So now, which fluid strategy to use? How much fluid to use? And suppose there are some patients coming for seizures, heart attacks, stroke. So all these are emergency situations. We cannot wait for the patients at times to give us consent to start the management or start the treatment. But we do need to come up with better ideas, and we need to conduct the research for better alternatives, better management, so that it improves the health. So in these situations, then it's a dilemma on when to take the informed consent. From whom shall we take this? The patient might be unconscious. He might not be willing to do. He might not be in the right state of mind at that time. So all these emergency situations, there comes a dilemma of how we can conduct the research ethically when the patient has not consented for this research. So clinical practice and clinical research while performing in ICU is a very thin line. So, we always use this judgment, and there are slight differences where you will have to modify your planned treatment as per the progress of the patient. So, you must have laid all your groundwork for your research, but this patient is different, and you might have to go for unconventional methods for the treatment. So then it again tries to, hinder your research results. So that is one more thing that needs to be taken care of. Then subject participation is important. Whether you might get a patient signed by the relatives that we do not want to continue the care. So again, these fractions of patients will not be counted in your study. The cost of it, I mean, in your regular trials, already the cost is so high, but still, you're not managing that patient in your hospital all the time. You're not have to pay. But now, when the patient enters into an ICU, the charges go up. The patient is occupying a bed, ventilator. There's so many other equipments and procedures being performed, and so many things going on that requires a cost. So, who will bear that cost for this? And so many exclusion criteria are present that eventually there might be another power studies. So all this, just plays on your mind, and you might swindle towards maybe a non-ethical research side in ICU. So now as we go on, and the questions to ask: can a substitute decision makers give consent for the research on behalf of the patient if the patient is unconscious? So yes, in certain circumstances, and there have been these rules and guidelines on how we can take the consent if the patient is unable to give or provide the consent at the same time. But again, that thing comes up: which relative, which person are we taking to, what are their interests, and is it in the best interest of the patient? Like, would have the patient wanted this or no? So this is very critical to know before we enroll them and before we take that patient consent or other the substitute consent in this. Then disclosures required for clinical decision making. Now the risks are very high, the adverse events that can occur are very high, and what all we have to disclose to the patient or to the patient bystanders when enrolling the research. So all these things, plays on your mind, and it provides, like, it's more riskier than it is beneficial. So it needs to be very proper in how your disclosures are put, how you show your what are the benefits in this research, and how it can prove them a little in trouble for this research. So what happens after the patient regains capacity to understand, to know, okay, I have been enrolled. Now, once the patient is conscious, you need to inform them that, okay, now you're part of research, and would you like to continue or discontinue? Because the patient might have a different thinking now, going through all the trauma or whatever the condition that patient might have gone through. And there might be a change in the way they have thought of their life, what they are willing to do and not willing to do ahead. Now, if any harm occurs, then who is the liable one? Suppose if I do enroll this patient without their consent and it was a need of the hour. So, and by chance, if anything goes wrong, so who will be liable? So all these things need to be discussed. They need to be laid out and discussed with the ethics board. Now, before going to any conducting a research, like we have seen all the principles and everything, but the idea of a research should have there be we have so many treatment options already available, so there should be a reasonable doubt that the next treatment that we are trying to test should be a little more beneficial than the previous one, and there should be less harm, or there should be this undecisiveness that which one treatment is better, whether treatment A or treatment B will be better. If that is not present, then this any study should not be carried forwarded. So there should be a genuine uncertainty of which treatment is better or not. So this term, this is equipoise, that we try to search in each and every research. And this research is mostly of conducting of 2-arm study, a 3-arm study, where treatment A and B are present. So these are just a group of examples that I've laid down here while enrolling a patient in the COVID study, where we didn't know very much about any of the drugs. Will it work or will it not work? But still, we had to enroll because at that time we had no data at all for any of the treatment arms. Later on, we came to know, and then we get to a better ahead of the COVID-19. Then, uh, like already we have warfarin for one set of treatment, but still there are so many adverse effects, and we need to test out DOACs in certain cases where it can be better or not. So again, these uncertainties play on your mind and which treatment is better. So just an example of how equipoise works. So there should be an analysis of risk at all times. So there are two types of interventions that you can see. One is therapeutic and one is non-therapeutic. So in therapeutic, you have surgical procedures, you have various ventilation interventions, and so many that that changes the path of how the patient responds. Now the non-therapeutic interventions are also there, like suppose drawing blood samples or performing a TDM, which will not have a direct effect on the patient's health, but yes, it will collect key information regarding the processes and regarding the treatment that will further make you analyze what kind of further interventions that needs to be undertaken. So now in this particular set of therapeutic versus non-therapeutic, again, the cost thing comes up in your research, and whether these non-therapeutic interventions, how much risk do they pose and how much benefit will they have on this particular research topic, that always needs to be in mind. Then equipoise must exist for therapeutic procedures, as we saw earlier. Why it is important? If the studies, if one arm is non-inferior, or just for non-inferiority we are conducting this research, makes no sense. There should be some benefit that should be coming up with that particular drug. The non-therapeutic procedures should be deemed reasonable in relation to the knowledge gain. So just like that I told before, like we need to bifurcate and see what kind of knowledge that we are going to gain and how much application does it hold to the actual research and therapeutic interventions. So in this, the independent review board plays a very key role in asking these questions. Apologies. So asking these questions and knowing what are the risks, and accordingly what all the inclusion criteria should be set, the exclusion criteria, what will be the methodology of the research, and laying the groundwork for the research initially, and what all the difficulties that are going to get raised, and how, if informed consent is not provided, then secondary informed consent, who will be the person to give. So all this comes with the independent review board and the ethics committee. So, and one more key component that will come is a very debatable one, is the clinical research involving vulnerable patients, a pregnant patient and children. This research is where, these sensitive populations are at risk of harm even more so. So in ICU, pregnant patients conducting research in them, the risk are doubled. So how we can minimize the risk, and from the already available data, whatever is there should be analyzed first. This all data, and regarding that, after that, we can take a step of which treatment to go ahead with. So this is one just short groundwork or a workflow that can be undertaken once set your protocol, then your study hypothesis with the inclusions of whether you are including all those vulnerable population or not, then your therapeutic procedures, then all these things must, just your ethical reasons should be matched, and then you go ahead with the research. For the non-therapeutic procedures, you have also various steps. You can go through this and see all the guidelines, and they show how you can conduct your research. So very useful tool here for conducting a research, this a workflow. So regarding the principles, just like how it is respect for persons, we have to take informed consent, and with disclosure should be there. The patient should be able to understand the information that has been provided. And, if it is shown halfway, some way, this, that, it's not clear, that means you are ethically wrong in conducting this research, because, you are not clear, you are probably not clear with the patients also, and there might be language barriers, there might be social barriers behind this. In India, we have so many different beliefs, different societies, different cultures, and accepting all the interventions is not possible. Some say, they are not okay with particular intervention. So all this needs, all this planning and all this needs to be disclosed to the patient or the patient's subordinate. Then for the surrogates as well. So respect for enrolled subjects, then assurance of privacy and confidentiality. That is a very important step while performing an ethical research. Withdrawal should be permitted. It's not like, they should be given an option that, okay, if you do not wish to continue this trial, and what will be the benefits, what will be the risk if they get withdrawn, it should not be prejudiced. These patients, if you withdraw from this, you will not be given so and so compensation, or you will not be given the proper care. No, this should not be coerced. It should be in a well-mannered way, and they should know that okay to withdraw from this research, and they will initiate, the standard way of care that that is different from the research. Then monitoring of the subject welfare, it is not just during the study, the post-study, everything needs to be monitored. Then dissemination of research results. Once we receive this results, it needs to be discussed, it needs to be studied. The just not the knowledge, and it will just the knowledge, gaining knowledge is very important, but also, the social value, what good are we doing with this research, that needs to be there. And it should provide a reliable and valid data with a favorable risk benefit. So risks should be first identified, they should be minimized, with benefits maximized, and should be reasonable to potential benefits to subjects and society. An independent review must be done before all this are entrusted, and they should review all the key aspects of the research. Justice should be there. It should be fair selection, whether it is randomization or any other selection for placebo group or maybe an intervention group. So all this should be a fair selection. There should be an equal distribution. Everybody should get an equal chance. Like suppose a COVID vaccine, when we had this research during the COVID vaccine. So it should be a fair selection of the population. It should not be prejudiced or any bias should be there. So just going through this one case study that I found very interesting. It showed all the difficulties in conducting an ICU research. So it was a prospective observational study of consecutive adult ICU patients for thromboprophylaxis with dalteparin in patients with and without AKI treated with renal replacement therapy. Informed consent for participation was obtained from the patients or their next of kin in cases when patients were incompetent to give consent. And when the consent was provided from next of kin, they later informed the patients that they were included and they had the right to withdraw from the study. So very good framework of this initial research where they showed, the consent and everything. So as you can see, initially they got the admissions that they got into ICU were 2,419. So enrollment was 2,419. But just on the right hand side, you can see how many got excluded for the various reasons. Therapeutic anticoagulation was required. So again, thromboprophylaxis was out the window, CKD, and so many exclusion criteria they must have laid down, age less than 18 years. So all these factors, coming up, then only 279 patients were eligible. And again, after that, eligible patients, another 204 were eliminated from the study. So remaining with only 70 patients at the end for available for analysis. So just how difficult it becomes to plan a study. And, if you have a target of a good, say, if you want to hit a target of 500 patients, how will you be able to conduct a research when you have so many exclusion criteria? So there's always this side, where you want to leave some of the ethical reasons behind and still want to enroll the study. So that will be a very wrong way to go ahead. So just how the bifurcation for the omitted patients, the 204 that were omitted out of the 279. So practical reasons, 133, medical reasons, various other 31, and legal or ethical reasons were 40. So again, a major chunk also is involved because of the ethical reasoning for omitting a patient. So what could be the ethical reasons for omission? So lack of capacity to include like unavailability of investigators, missed follow-up or holiday period, previous inclusions or readmissions. Again, we need to be mindful of that, whether they were included in previous or not. Then communication barriers. In India also, we see so many people, we are unable to convey our ways information regarding the research. So always maybe in their place also there was a communication barrier where understanding the consent was a difficult thing. Then psychiatric conditions where how you can inform that patient regarding their benefits and risk and everything regarding the details about the research. Then end of life care is one more ethical aspect that comes into play, and you cannot go ahead with the research in these kind of situations. So again, this gets diluted, and you might end up with a study that is not that powered. So everything needs to be considered regarding this, the equipoise, and how you can create a meaningful research out of this with such a barriers in ICU. So one more thing, just like the perspective of ICU patients on deferred consent. So if they were taken into a study and they later on deferred for their consent. So how do they feel when they were included in the study without proper consent? And after they got the results out of it and they were available for the questionnaire, that how did they feel when they were included in the research study without initial consent? So if you see the Q1 to Q4, these are the four quartiles, with the Q1 being the quality of life. So they matched the results with the quality of life. Suppose if I was included in a research and I deteriorated a lot, although I survived, but I could always have this question because of this research, maybe my life deteriorated. If I would have been in another group, maybe I could have done better. So all these questions and all this thought process come into the patient. So eventually, are we doing justice to the patient? Is this what the patient wants? So this conflict is always there. So if you can see in this graph, from Q1 to Q4, where Q1 being the lowest quality of life, whereas Q4 being a very good one, after the research participation, the content percentage reduces as the quality of life decreases. So this always will be a question in ICU, whether, if I am a survivor of after research, if my quality of life decreases, maybe I will blame the research study. So because I was not given consent initially. So again, this needs to be a consideration, but very few things are available to, how we can go about it and how we can resolve this. So it's a very tricky situation when considering an ICU research. Now, the hot topic, AI in research. Now, in so many fields, we have seen AI being engrossed, being used left, right, and center. And soon, and we are seeing day by day growing the use of AI being growing day by day in our medical practice, in ICU as well. So, how does it play a role in research when we are doing clinical research? Suppose we feed the data to AI regarding the various parameters of the patient, and it comes to a conclusion. And we start treatment according based on that. Is it justifiable in a research where, the question arises like, how did it work? What were the decisions? How did the AI take those decisions? And if it is in one arm versus, if we have a two arm, like a study where we are testing whether the AI is better than the clinician's judgment for diagnosis or for the management or any particular treatment. So how does this work? And, even if AI comes out better than that, then who will be able to explain to the patient that what they received the treatment or the treatment was from the AI and it was just based on an algorithm and not the clinician's judgment. So that again, that arises a question of how to formulate that research layout. What will be the key things that needs to be informed to the patient, and the harms of what AI, if suppose it misdiagnoses or leads to a wrong conclusion, or it shows unnecessary diagnosis or unnecessary things, and still it is getting treated. So all these questions come into arise, and there will always this complexity. So as probably in future, as the AI use increases, we probably know more better of how we can include AI in research. There are a lot of RCTs going on in this way. So again, this informed consent challenges will be there. It will be very difficult to explain the patients of how AI is making decisions for research on their behalf, of which like for randomization, how is AI going to randomize the patient? How is not going to be biased for any particular algorithm that is being developed? And in this algorithm that is decision making, how it will fare against the human judgment. Because as we have seen a lot of times in our practice, that a clinician's judgment is, a little different. What's in the books, and at times, you go off that practice where the clinician is able to judge, okay, now the patient's condition might go into this, so we need to prepare for this and that. And how it is different from the AI algorithmic, which is very straightforward and it is based on the data that is given to it. So again, that biases can be there, what data is given to the AI. Then data privacy. If we feed this data, where does it end up? So uh, it's not secure. It's not, probably the privacy of the patient might be compromised in this all. And the post-treatment accountability and liability. If I say that AI has made the decision for you, then who is accountable for if the wrong decision was made or any harm that occurs? Even in normal research, the harm is there. In that we know, we have already taken the consent and everything. So all these principles, all these things needs proper review, proper guidelines, and probably after that, an AI surely in future will have a very important role, but it should be under the ethical bounds that researches are conducted. So key takeaways from my presentation, I would like to say the complexity of the critical care research, the urgency of decision that has to be made, and very limited duration of time in which we need to make a decision, maybe into an selection of patient in which arm that we need to put in, the various randomizations, and how we can uh, come up with the best possible way so that the patients are exposed to minimal risk and maximize benefit. Unpredictable patient conditions, we never know when the patient, how the patient will respond in ICU. Already it's a complex case. Then the ethical dilemmas that come in, the ethical frameworks which ensures should ensure the integrity, like the patient rights, fairness, and maintaining the scientific validity. Equipoise must be present to conduct any clinical research, especially in RCT or those involving treatment arms. And the risk benefit must be assessed and limits set for risk tolerated. A couple of references here that but this is a very old article from NEJM which talks about on equipoise and ethics of clinical research. The second one, a very good thematic series on ethics in ICU, which will give you more information about how the concepts and everything came into play. Then this is the ICMR ethical guidelines that have been published. Thank you.
Yes, Abdi Hussain sir, it was very fruitful session, and also coming to your slides, you just started with the introduction and the history how it came, and also you talked about the Declaration of Helsinki, ethical requirements of clinical research, how we can conduct, and also you just made a clear points like which we were having a doubts and all, like a social values, scientific validity, and the participation selection, favorable risk benefits and all. Almost you have covered everything and my questions have cleared in slides itself. But coming to AI part, I have only one question,
Yeah.
that is like what are the ethical implications, sir, of integrating digital health technology? Example like remote monitoring or AI drives.
So, suppose like if I there's one thing that I read about the study of AI being used. Some an diagnosis for pneumonia. X-rays were shown to the AI and then to the clinician in a separate room. With their so what the clinician saw in the diagnosis that was taken and what diagnosis was made by the AI. So comparing those, there's always this chance that the AI will fare better. There's a chance of that happening and in the study. And so ethically, so now would we go ahead with the AI on room? So there's always this thing, how will AI take the place in treating the patient? There's so many information and data sets available at the same time for the AI to process and make a better judgment. Now, ethically, now to see the main thing that comes into force is how this AI is going to be explained to the patient. Now, if suppose I'm the end user for this particular research and my decision being made by AI, so how will I be, ensured that it's fair? Because at times it is based on algorithms and various processes, and it might, have this bias of putting me in another arm rather than another arm because it thinks that according to my data profile I'm a better suit for this particular arm A. So this should not be there. The algorithm should be set that much that the biases should not be there. And once the AI has given the diagnosis and the treatment for this particular, after diagnosing it, then how it is conveyed to me. Now it is given to another clinician. Then how this is explained to various people. Now in India, you have so many barriers. People are unable to understand at times the full length of the research, and this concept of research, makes them think that already I'm an experiment. So a non-human touch in this again will make them feel insecure about their involvement in a research project. and the harms that might occur. So now, if I'm already in this mindset that, I'm not very sure about this research, okay, let's go ahead with this. Maybe this will be right for me. But what happens if some harm occurs to me? Then who will be liable? How will I put the blame on AI for this particular harm that has been done to me? In research, you have various compensation methods. You have already been informed about, what are the risks and they are okay for the risk. But when you're conducting research, it's totally different thing. So all those concepts and ethics, they are base difficulties. And equipoise, like one thing I was reading, equipoise with AI. And see, if you have AI winning a lot of things in this, being better than everything, but we cannot straightforward go ahead with an RCT like this. It might be very difficult. First, we need to understand through observational studies and how this AI is working, and then probably push it to a phase 4 or then probably an RCT. That one.
Thank you, sir. Thank you for clearing my doubts and all. Like I can see the spotlight words in your slides also, sir. The topic itself, it was ethical, because nowadays the healthcare sectors or any of the public sectors are forgetting about the ethics. So you took a ethical concern. That was a great thing, and also you talked about the justice, like a fair selection or a fairness in the project and all. It was very, very fruitful, sir. Thank you. Thank you so much from the team, FCPI, for teaching us the ethical concern in critical care research, sir.
Absolutely. I think so. Going for the new uh, researchers out there in clinical pharmacy and anyone else in any other field needs to remember these principles and make sure, for to get the best outcome from the results, we don't do any harm at the same time.
Sir.
Thank you, Pan. Thank you so much.
Yes, sir. Thank you. Thank you so much, sir.